At OnlineMedEd, the videos are free. You can learn what you need to learn. But to get the most out of the course, access the premium content. Sign up now to get access.
In this lesson, we're going to talk about eating disorders. And what that means primarily is separating anorexia nervosa from bulimia nervosa. Anorexia, bulimia. I'm going to state things in sweeping generalities, and I'm going to juxtapose the two diseases against each other as though they are mirror opposites. Of course, in life this is not true, and there's a lot of crossover between the two diseases. As you begin to study these diseases at the foundational level, I want you to see them as two distinct diseases that do not overlap. Learn them that way, and it will stick. Before we talk about those two diseases, I want to talk about the different methods that girls who have this disease might use. The first is restriction. And I want you to associate restriction with anorexia. Restriction comes in the way of reducing caloric intake and increasing caloric expenditure. That may come in the way of diet, where they eat less or less caloric foods, or they simply fast. That is, they don't eat. An increased caloric expenditure is simply exercise, generally to excess. The problem is the people who are at highest risk for eating disorders are going to be the teens to 20s and women, the same time in which competitive athletes might want to train and compete. So it's hard to tell sometimes if a dancer, a gymnast, or an athlete is simply being competitive or if they have an eating disorder. So the people who are most likely to suffer from these diseases are also most likely to hide it. Restriction, decreased caloric intake, increased caloric expenditure. The other one is the purge. I want you to associate this with bulimia. Purge means even though the nutrients are ingested, you find a way so that they don't get into the rest of the body. Two ways to do that, the in-hole and the out-hole. Purge can be accomplished with emesis or with laxative abuse. Emesis is going to be very obvious in a vignette. It may not be obvious in a person. The more she does emesis, the more these signs will predominate. Since emesis is acidic and it burns, you're going to look for the things that come into contact with acid often. That is going to be the teeth, presenting with dental erosions, and the back of the hands, dorsal hand scars, because usually the emesis is self-induced. And constant emesis may lead to parotid swelling. Doing a lot of emesis is going to cause some metabolic derangements. When you vomit, you're losing hydrogen ion and potassium. And often with potassium goes magnesium. So what you should see is a low potassium and a low mag. If you're losing hydrogen ions, you're losing acid, what you'll see is a metabolic alkalosis. Now I have trouble with diarrhea. For whatever reason, I have a brain fart when I talk about diarrhea and it's metabolic acidosis. So what I do is I remember that emesis causes alkalosis, laxatives cause the other one. Diarrhea causes a loss of bicarb, not the loss of fluid, so you'll see a metabolic acidosis with laxative abuse. And of course, there might be the chief complaint of diarrhea. Now I'm saying she instead of they. That is because the biggest trend that we've noticed is that this occurs in a female to male ratio of about 10 to 1. So you can bet with a 10 to 1, the clinical vignette is going to be female. If there is an eating disorder or a body dysmorphic disorder-ish question and there's a man, it's probably going to be the disorder that involves bodybuilding, too much muscle, excess in the gym, and testosterone abuse. If you've got an eating disorder question, it's probably going to be a female. This happens primarily in the teens to 20s. And as we said, restriction I want you to associate with anorexia and purge with bulimia. Can a bulimic patient binge and then carry out restriction, not eating for a while, exercising too much? Of course. Can someone with anorexia purge? Sure. But I want you to make this concrete, juxtaposed association that's going to help you remember the diseases by comparing them. Let's move into the difference between anorexia and bulimia. Since anorexia is the harder one, I'm going to start with that first. And we're going to compare the two based on the actual body weight, the girl's self-image, what induces the anxiety in the disorder, the method, the signs and symptoms you'd expect to see, whether or not you'll need to hospitalize, and if you do, why, the treatment, and some stuff you should know, and follow-up. Start with anorexia, build it as though it is a discrete disease with no overlap, juxtapose it against bulimia, and you should be able to contain these diseases pretty easily. The body weight of anorexia is underweight. Now, all of these have some sort of body dysmorphic disorder, but the problem with anorexia is that even though the girl is underweight, she thinks or fears that she might become fat. So her self-image is woefully decreased, often seeing an unrealistic vision of herself, even when confronted with images or mirrors. And the thing about anorexia is that the anxiety is not about her actual weight. It is about fearing becoming or being fat. The other problem is that there is no insight. That is, despite being shown how sick she is, she hasn't the ability to see that she is woefully underweight and hurting herself. The method typically used is going to be restriction, as we just talked about. And what you should look for in the way of signs and symptoms is going to be that of malnourished. You're going to see hypothyroid but thin. That's what I want you to think, hypothyroid but thin. You're going to see things like lanugo and amenorrhea, cold intolerance, but she's also emaciated. This is basically her body lacks the nutrition and the nourishment necessary to carry out the basic routine functions. The time to hospitalize a patient is when the anorexia is extreme, and that is defined by any of three things. The one I want you to remember, because this is actually how we stratify the severity of anorexia, which is based on the BMI. Don't memorize what's what. Just know that extreme is defined as a BMI less than 16. We used to use the ideal body weight, and that was 85% or less of the ideal body weight based on their height. But now I want you to focus on the BMI. BMI less than 16 is extreme. Or you might see any sort of electrolyte disorders. Leukopenia, that means they lack the nutrition to develop an immune system. Or again, severe hypothyroid, but they're thin, bradycardia hypotension. If you hospitalize, you remove someone's rights, it better be for a good reason. So if you hospitalize somebody, you're going to force feeds or use that as a time to replenish IV fluids and electrolytes. You may also begin the outpatient therapy here with medications and therapy, but the hospitalization is to get their nutrition and electrolytes back to normal. The outpatient treatment, which may begin in the hospital, is going to be antipsychotics. That's first line. And that sounds weird, especially since this is a body dysmorphic disorder, an anxiety disorder. The inclination is to go to SSRIs or SNRIs. And as we'll see, that's almost always right. But if you have a straightforward anorexia case, antipsychotics is first line. And so that's what I want you to remember, because it's going to be weird. It's going to be SSRI, SNRI for every other disease in this video, except first-line antipsychotics, anorexia. And of course, you want to help them out with cognitive behavioral therapy. But with anorexia is often comorbid conditions like OCD or major depressive disorder. If that's the case, there's your indication to go to the SSRI or the SNRI. Treatment with bulimia and anorexia with OCD or major depressive disorder, first-line therapy, SSRI, SNRI. If it's straightforward anorexia, first-line medication therapy, antipsychotic. All right, we've built anorexia, and now we're going to use it to juxtapose against bulimia. And you'll see how much easier bulimia is. And if you learn anorexia, which is what I want you to do because it's the harder one, it becomes very easy to extrapolate to bulimia. In bulimia, the body weight is usually normal. They may be overweight, but they're going to teeter on the normal range. And they don't feel good about themselves, so they're going to have a decreased self-image. But that's not what induces the anxiety. What induces the anxiety is the binge. In bulimia, you binge. And the binge is an uncontrolled eating. Can't stop eating what's in front of you, eat too much, eat too often. Now she knows there is insight. That's bad. She feels bad about it. And so the method most commonly associated with bulimia, opposite from restriction, is the purge. So you usually hear bulimia being binge purge. There isn't really a sign or symptom associated with bulimia itself. So what you're going to see is a normal patient. But you might see the signs of the purge. And depending on what she's using, laxatives or emesis, will change the physical presentation. Very rarely does bulimia become bad enough where you need to hospitalize it. Because she's eating, she has this nutrition, she's depriving herself of that nutrition by purging, but often they're normal weight and don't have this extreme presentation of an anorexia patient. The treatment for bulimia, first line, is going to be SSRI, SNRIs. And you're going to use cognitive behavioral therapy. So I'll say it again, in all cases, the SSRI is correct, best answer, except when it's a straightforward anorexia case not associated with OCD or depression, in which case it's antipsychotics. And for whatever reason, the boards love the association of bulimia and bupropion. Never use bupropion. There's an increased risk of seizure. To finish off this lesson, I want to finish with binge eating disorder. As you might have guessed, that's going to be the binge, but without the purge. And because if you just eat a whole lot and you can't control yourself, you're likely to be obese. So if you see an eating disorder with a woman or a girl and she's obese, it's probably binge eating. If you see an eating disorder question with a girl and she's normal weight, it's probably bulimia. If you see an eating disorder question with a girl and she's underweight, it's probably anorexia. If you learn anorexia, the thing that is she's underweight but fears becoming fat but thinks she is fat, without the ability to see how dangerous it is, using restriction and presenting as malnourished, then you compare that and extrapolate bulimia to be the normal body weight, cares about the binge, that's what she doesn't like about herself, and she usually uses purge to get rid of it. I'll say it again to conclude, they overlap. Bulimia can restrict, anorexia can binge purge. But what I want you to do is learn it this way so that you keep them straight in your head as separate diseases. And when you finally encounter patients, you can learn the truth. The last thing is that most of these patients who die from these diseases will die of a medical complication not related to the disease or suicide. Identify the method, know the trends, and be able to separate binge eating disorder from anorexia from bulimia. That is, eating disorders. Become a better doctor. Subscribe now to get access to our premium content.